Right, we're about 1:45, so I think we'll make a start if that's okay. So welcome everybody to the Festival of Ideas. I'm sure for a lot of you it won't be the first talk you've come to, but if it is, then very much welcome to it. I think you know how things work. Just a couple of housekeeping points. Don't think we'll need to evacuate, but if we do, you all know we can go out the way we came straight in. And I think also just to remind you to put your phones on silent. I've just remembered to do mine as well at the last minute to make sure I'm not the one doing that. Right, so for the next 40 minutes or so, I'll be talking about medicine, the health system, and the environment, and the interconnectedness between the two. I'm not going to go into huge detail about the environment and climate change. I think we'll just take it for read that we agree this is an important thing. So I won't go into the facts and figures too much on that. Very briefly, I'll touch on it, but no detail. But I will talk in a bit more detail about the health system and how we make decisions in the health system, and therefore how do we start to factor in environmental outcomes that we might want to consider. The spoiler before I get to the end, and just to manage expectations, is that there are no easy solutions to this at all. So I'm absolutely not going to be saying we need to do this, and this, and everything will be fine as long as we do that. So, but I'd be really keen on questions at the end as well. I think we've got 20 minutes for discussion at the end. And as you'll hopefully see as this goes on, it's a quite complicated area, and there's lots to think about. And it's one of those areas that the more you start to unravel it, the more you realise there are extra things that we need to solve and think about. So I'd be really open to any ideas and suggestions when we get to that stage as well. Great. So I'll start off just very, very briefly talking about the National Health Service in the UK. It's been around for a long time now, and it's fantastic as well. I will say that much. It's done some wonderful things in the time it's been going. So life expectancy is just one metric we might look at. Just before the NHS was set up, life expectancy in the UK was 64 years. It's now about 81, just over 81 years. When you work that out, actually, over that period of time, we've gone up in life expectancy 17 years. And every single day that the NHS has been running, life expectancy creeps up by 5 hours or so. And I think that's amazing. That's every day for the last 7 or 8 decades we've been eking up that life expectancy. So big well done to the NHS there. And of course, it's got full coverage for everybody. That's something that not every country have. I know we all complain about not being able to get appointments, but when you look at the figures on it, there are 1.6 million patient contacts with the NHS every single day. So every day throughout the year, 1.6 million people. Not all GP visits and things like that, obviously. But it's amazing the amount of stuff the NHS does as well. So we should never take that for granted. And remembering that it's about equality as well, so it's a public funded organisation. We don't have to pay for things at the point of access. And particularly, if any of us come down with long-term diseases, we don't tend to have the same financial burden that people in pretty much every other country in the world has when these things hit. So I do think there's a huge amount of praise to be sung for the NHS. And I just wanted to start off with that, saying that's something that we don't necessarily want to lose. But at the same time, we are worried about climate change as well. Again, I said I wouldn't go into the facts and figures too much, but we know there's roughly about a 1.2 degree increase since pre-industrial times in temperature. The point of no return, as we're told, is 1.5 degrees. We're getting closer and closer to that. Places around the world are thinning, the sea levels are going up. All of these things are bad things that we desperately don't want to happen. So they're the two main things I want to start off saying. We like the NHS, we want to try to keep it doing all the good things it does, but we are also worried about the environment, and we want to do what we can to try to stop harm there. So I'll start off maybe for 10 minutes or so, just talking about how we make decisions within the health system, and particularly from an economics perspective. That's where I come from. I'm a health economist. And so I want to talk about some of the basics that we do here. I don't want to get too into economics, but economics is the study of blah, 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 all these different things. But really what we're trying to say is make the most of what you have. You've got limited things, whether that's time, money, resources, whatever it is. Economics is about making the most of what we have. And the NHS has limited funds as well. So really, health economics is about making the most of the limited funds that the NHS have. And to understand that, it's good to think about, what do we do with this money? Well, if we want to spend more money on something new, if some new medicine comes along or a new device, or we want to open a new hospital, if we want to spend that money on healthcare, we've got 3 choices as to where that money might come from. The first area is we could reduce spending on something else. We could cut back on some doctors or medicine or ambulances or anything else in the healthcare system, do a bit less of that. Now we'll have more money to do the new thing that we want to do. If we're not willing to do that, we might want to stop spending outside the health system. So we could cut back on schools or policing or mending the potholes in the roads, things like that. All these different things, we might cut back on those things. If we're still not willing to cut back on anything else, then we can increase taxes and say we'll get some money through in that way. Unfortunately, as a health economist and as somebody who is working within the health system itself, these two things here are outside the remit. We're not allowed to just say schools stop spending money and give it to us instead so we can spend it on healthcare. We're not allowed to say increase the taxes and get money that way. So every time the NHS makes a decision about spending money on something new, it has to accept that it's not going to spend that on something else. It's going to have to cut back on doctors, nurses, ambulances, MRI scanners, anything that they currently do. They'll have to cut back on this. And of course, that's a difficult decision. So if the NHS does want to cut its spending on something, where on earth does it cut this spending from? Does it take it from staff costs, infrastructure, medicine, equipment, other stuff? There's a ton of money that the NHS is spending. Lots of different areas we might kind of take a chunk out of if we want to cut the spending. Might be that we take a little bit out of everything. Either way, that's bad, and we don't really want to cut back on spending. So a loss of spending in any area of the NHS will have some bad consequences, things we wanted to avoid. So, for example, it might have an impact on survival rates. People might start dying younger or earlier. It might be that it impacts on people's quality of life. They're not receiving the same treatments they would have otherwise had, or the treatments they could have had. So it might impact on quality of life. It might impact on things like recovery times and the future costs. So by not doing something now, it might just shove the problem into the future and we have to pay for extra things in the future because we didn't prevent them now. So whenever we cut spending, it will have some nasty consequences. Trying to measure all that, as you can imagine, is quite complicated, and I don't know if people have ever heard of something called the Quality Adjusted Life Year, or QALYs. These are what we tend to use to try and make decisions. QALYs are a measure that represents length of life and quality of life, and we combine the two together. Just to give you a quick idea of how QALYs work, we have a scale, and we call it a kind of quality of life scale, or a health-related quality of life scale, and it goes from 1, which is what we call full health, or perfect health, or normal health. Nobody can ever quite decide what 1 really means on this scale, but it's the best health you can imagine. Right down to 0, which is dead, and everybody agrees that 0 is the worst kind of dead state that we can be in. So we all agree at the bottom. We can kind of roughly agree what the top of that scale means. And in theory, every single kind of health condition you can think of would fall somewhere on this scale. So for example, we might say somebody with no health problems is right at the top of the scale. Somebody who has diabetes is a little bit further down, but not too far down. If their diabetes progressed to chronic kidney disease, then that becomes a bit more severe and the quality of life drops off. If the chronic kidney disease progressed to being dependent on dialysis, it might be significantly worse again. So these are all hypothetical values. As you can imagine, they're not exact numbers either. I think if you looked at a different study, you might find that somebody else measures them and gets different scores. And I always think, if this is the first time you've heard this kind of scale, it does sound peculiar, and it is peculiar. It's 0 to 1, 0.9, 0.8, and so on. If somebody says to you, hello, how are you feeling? Would you reply 0.933, I think, today? You would describe it qualitatively. You would say, I'm okay, but my back hurts a bit today, or I didn't sleep very well last night, I've got a bit of a headache, or I'm fine. You would describe it in words, but we're all geeks in the economics world, and we need to put numbers on all of these things. So we kind of have to do it. But I'm not pretending for a second that this is the right answer. You could ask 10 different people and get 10 different scores for these things. And we do that. We ask thousands of people every time we do it to try and take an average. But that's the scale of quality of life there. We're also interested in length of life, so time along the bottom as well, because living for longer is generally seen as a good thing. So we want to know, how long does somebody experience each of these health states? And a very simple way of thinking of it is, maybe if somebody was in full health for exactly 10 years and then they suddenly dropped dead after 10 years, we can assume it's painless just at that point, they suddenly dropped dead, that person would get 10 quality adjusted life years. They get 10 QALYs. They get 10 lots of full health. That's 10 QALYs. Nice and easy to work out. If their quality of life wasn't so good and it was 0.8 and they lived for 10 years, they'd get 8 quality adjusted life years. So it's not as good. They still live as long, but the quality of life isn't as good, therefore they don't get as many qualities. You could do this by shorter lifetime, poorer quality of life, and this person's getting 3 quality adjusted life years and so on. And it's quite useful because it means that we can measure the benefits of a new intervention. So if we went back to this person who lived for 10 years at 0.8 health versus somebody who lived for 5 years at 0.6 health, you can see that if we could give them some medicine, let's say, that improved their length of life and their quality of life, that person would get an extra 5 quality adjusted life years, 5 extra qualities for that medicine. So it's a really neat way of us being able to put a value on how good a medicine is by how much it improves your quality of life and how much it improves your length of life. Just to avoid you thinking it's overly simple, we can show changes in quality of life over time as well. Obviously somebody might have a certain quality of life for a bit and then get worse and live a bit longer. In that case, we just work out the qualities the same way, we just do it in a bit more of a kind of chunky way. It could even be like this, and you get something like 5.26571 qualities. But that's our job, that's what we do. We try and measure these complicated pathways that people go through, estimate how many qualities they would get with and without treatment, and that gives us a kind of valuation of how good that treatment is. And that works for anything, that's the beauty of this. It works for cancer, for diabetes, for maternity care, anything you can think of. We can measure the outcomes in qualities. Again, I'm always happy to discuss the limitations of qualities. It's not for discussion today. They're not perfect by any stretch. But it is quite useful for allowing us to understand what happens when we stop spending money on something in the NHS. What will the consequence be? And so that's what we come to here. So I've said it is estimated. It's estimated by, let's just say it's estimated by people. Some people do that. Some people disagree with this. Some people think that the number's different. Some people think it's higher. Some people think it's lower. But if anybody's familiar with NICE, the National Institute for Health and Care Excellence, they estimate that for every £20,000 that we lose in the NHS, the consequence of that will be that we'll lose one quality. We'll lose one quality adjusted life year. In theory, it might be one person dies 1 year early. It could be 2 people die half a year early. It could be 10 people lose 10% of the quality of life for 1 year. Any combination of those things. But the idea is if you walked into a hospital and opened the hypothetical till and just took £20,000 out of it and said you can't have that anymore, the consequence of that to that hospital's population for that year would be that they would lose about one quality, spread across the population. Of course, that means we can scale it up, because if you took 40,000 out, you'd lose 2 qualities. If you took £100,000 out, you'd lose 5 qualities. If you took £20 billion out, you'd lose 1 million qualities. So we can work out, if you take money away from the NHS, what's the consequence of that? And that allows us to make decisions about new medicines, because if we had a new medicine that cost £40,000, we know from this that we will lose 2 quality adjusted life years somewhere else in the health system. And therefore, we need this new medicine to make sure it gives us at least 2 extra qualities. If it doesn't give us 2 extra qualities, we've actually made our whole population more unhealthy overall. We've introduced a new medicine that works quite well, but actually we've caused more harm by taking money from somewhere else. It was probably doing a lot of good somewhere else. We've now taken that money and spent it on something that's only a bit good, and therefore we've made our whole population worse. So that's a really important thing for everything else I want to talk about when I'm talking about the impact on the environment as well. So it's important to remember that the impact of any decision in healthcare can be measured by its impact on total or net population health using qualities, and some decisions, good decisions hopefully, will increase total population health, and some decisions, maybe the bad decisions, will decrease net population health overall.
I'd like to ask a question.
Yeah, you can.
I was just looking at, like, supposing you cut the money by taking away 2 nurses.
Yep.
Or maybe half a consultant.
Yep.
And you kept on doing that. Can you measure the impact on the quality of life of your staff?
Of the staff?
Because that seems so important, like so many doctors have written about, especially junior doctors, about their dreadful experiences, but also
so working longer hours and making more mistakes and all these different things.
Well, not just the impact on the patients though, but
But on the
impact on them.
on the
because
staff,
they're
yeah.
part- yeah.
Yeah, absolutely. And again, I mean, that would be harder to quantify and measure. I should say that this £20,000 per quali trade-off is what they always call at the margin. That's kind of the next £20,000 you take off. I suppose as you keep taking it off more and more, it might have an even bigger impact, it might have a smaller impact, it might be more complicated and suddenly hit thresholds, and every time it means that one doctor is lost, then that has a kind of bigger impact.
Remembering a nurse who wouldn't sign a petition about staffing, increasing funding, because she said if the NHS gets more money, they'll just employ another management with a clipboard.
Yeah, well, that would be simple, wouldn't it? That would be an easy solution. We don't have easy solutions, but we do know that any cutting in funding will be bad, and it will be bad however you measure it. Yeah, so maybe that's an underestimate. Maybe there are other effects that aren't even captured in here. But it's worth me saying that all of this, it seems that we're only interested in health as the main output from a health system. If we're trying to maximise health, that's what we would do. But that's not necessarily what we want to do. There are lots of different things that medicines impact on. They do impact on population health, but they impact on innovation. Sometimes we want to approve a new medicine just because it's innovative and it gives us new ideas and it furthers medicine. I said earlier that the NHS is adding 5 hours to our life expectancy every day. That's through innovation. We don't want to stop that. We like the impact it has on equalities as well. We want to be fair about our health system. Maybe we could make population health higher but more unfair, and we might not want to do that. Productivity, getting people back to work, for example, is an important thing. It doesn't necessarily improve everybody's health, but it improves the economy's health, the productivity of a country as well. And then finally, well not finally because there are lots of things to think about, but finally on my slide, environmental impact of the medicine. That might not directly impact on people's health, certainly not just in the UK, but it's still an important impact of a medicine. Every time we approve a new medicine, it will have an impact on the environment. And improving environmental outcomes in the healthcare system is a hot topic, probably more recently in the last decade or so than it probably used to be, like many other things. But you can see worldwide, it's not just in the UK either. Lots of different places are talking about how health systems can adapt to be more friendly to the environment. A couple of just facts about this as well, just so we're all on the same page. The UK NHS accounts for about 4%, I think some people say 5% of the country's total greenhouse gas emissions. That is a huge percentage really when we think about it, a 20th of it. But then when you think how big the NHS is and what proportion of people in the UK work for the NHS, and I said 1.6 million contacts with the NHS every day, they are doing a lot, so it's not surprising it has that impact. The NHS wants to do something about the environment. It said it would like to be net zero by 2040, which isn't that far away, and it wants to have an 80% reduction in CO2 emissions by 2028 to 2032, which is really not that far away. However, I've found my personal experience has been when we've really tried to push as to how is this going to be achieved, how are we going to get to net zero, the discussions tended to be about service-wide policies like encouraging staff to get public transport to work, not to drive to work and so on. It's been about the NHS's own transport, so electric ambulances rather than petrol ambulances and so on. And there's been far less, I think, willingness to discuss the actual impact of things like which medicines to use. So whenever I've said, would you be willing to stop using a medicine if it was effective but harmful to the environment? Would you be willing to stop doing that if it made people more ill? And that conversation never seems to go anywhere. Oh no, we'd never want to harm patients. And no, I'm fine with that if you want to say we'll never harm patients. But I'm struggling to see how can we get to net zero if we're not really willing to make those trade-offs. So that's what I want to talk about here as well. Also worth me just pointing out that we often talk about CO2 and net zero and things like that, but there are actually tons more dimensions to environmental impact. So all greenhouse gas emissions, not just CO2, water pollution, depletion of rare resources, we'll run out of some of these rare chemicals that we need to make medicines if we're not careful. The waste, the disposal of medicines, air pollution, loss of biodiversity. Lots of these things aren't talked about, I think, so much, just because they're quite hard to measure as well. It's easy to measure CO2 because you can just talk about how many tonnes of CO2 emissions there are. Really hard to talk about loss of biodiversity because I don't think anybody knows how do you measure the loss of biodiversity. Is it the number of animals that die? Is it the proportion of a species that dies out? Is it the number of species that become extinct? If it is the number of species that become extinct, are some species more important than others? I think if we're talking about polar bears and pandas or some particular type of microbe, then they're quite different things. I don't know. Nobody knows, really. Nobody knows how to value these things. And for that reason, I think we don't tend to have targets like we do for net zero and CO2. But it's definitely important to remember these are all important things and we shouldn't just shove them to one side because they're difficult to measure. I've talked about the impact of taking money away from the health system and how that impacts on our health. Now, the best estimate I can find for how much net zero targeting is going to cost us is from the Climate Change Committee, and they estimate about £50 billion per year. That's for the whole of the UK, not the health system. The whole of the UK will need to spend about £50 billion a year to help us get to net zero by the targets they've set. I've not seen a similar figure for the NHS, but if it's proportionally, so if we say that the NHS is about 4 or 5% of the total emissions, therefore if the NHS pays about 4 or 5% of the total of this, that'll be about £2.5 billion for the NHS. That's quite a chunk to cut out of the NHS. Using that table I showed before, if we just took £2.5 billion out of the NHS every year, that means we're going to be losing about 125 quality adjusted life years every year. So again, nobody's quite explained how this is going to happen. Are we expecting to spend £2.5 billion without there being an impact on human health? Are we just accepting that there will be an impact on human health and we just hope it doesn't get noticed too much? I'm not sure. There hasn't really been this open discussion about that yet, but that's about the best estimate I think we can have now for what the impact will be. I think it's also worth me emphasising that I think making any interventions in the health system more environmentally friendly will inevitably mean some more trade-offs. I don't think we can avoid this. Two different ways I think we could try and be more environmentally friendly. One might be just use a different treatment, say stop using that medicine and have this one instead. It has less water pollution or it has less CO2 emissions. Well, this new intervention, it might be better anyway, or it might be worse for us. If the new intervention is better for us and improves our health anyway, then why weren't we just doing it? It doesn't really matter about the environment. We should have just switched to it anyway. If it decreases health, then of course we're implicitly trading off a bit of our health to make this more environmentally friendly, which might be fine, but I think we just need to be open about that. The other way that we might do it is say, well, we'll give you the same treatment, but we'll just change how it's made or transported or produced or disposed of or so on. It might be that way is cheaper, or it might be that the new way is more expensive. Again, if it's cheaper, then why weren't we just doing that in the first place? They expected us to do it anyway. If it's more expensive, then of course spending more money on it means spending less money on something else, and therefore we'll have to trade off some overall health. It might be other people trading off their health indirectly, but there will be a trade-off. Quick case study just to say people are looking into this kind of thing. So diabetes is one good example of it. This paper that was published about 3 or 4 years ago looked at diabetes management, and they tried to say, if you manage somebody's blood sugar levels well in diabetes, does it help to reduce CO2 emissions? And they answered, yes, it does. Having effective management of diabetes will help to reduce carbon emissions. Problem is they didn't include the impact of the treatment itself. They just said, if you manage it well, it reduces emissions, so you stop people getting chronic kidney disease and dialysis and things like that. But they didn't really compare it against the treatment itself, mainly because there are so many different treatments, and I think they found it hard to work out. But they also only focused on CO2 emissions, and I thought that one was really interesting because if people are familiar with metformin, that's one of the more common treatments for diabetes. So it might be that metformin is the treatment that we use to manage diabetes and to reduce carbon emissions. But metformin is really famous for being quite bad for water pollution, for reasons I don't quite understand. I'm not a biologist, but metformin, you take your metformin in a tablet or whatever, you go to the toilet, you have a wee, it stays active in your system, it stays active in your wee, it stays active through the sewage system and out into the rivers, and then all the fish swimming around in the river are getting doses of metformin, and it's been shown, this paper here shows it, I think 25% of the world's rivers have noticeable levels of metformin in. But this is interesting because what it's telling us is that metformin might be good at reducing CO2 emissions, but might be bad at water pollution. And I think this is one of our big challenges. What do we do there? Which one of those is most important? How do we trade off CO2 against water pollution. How do you measure them in a unit that you can compare against each other? Don't think anybody's really pushed on that yet and tried to answer that question. There's certainly no easy answer that I'm aware of. To go even further on why I think all this is very, very hard to measure, and I'll caveat all of this by saying just because something's hard, it doesn't mean we shouldn't do it. So I'm not trying to be defensive here, but I'm saying that measuring environmental impact of things is really, really hard. So we could say, okay, we want to measure we'll call it CO2 outputs, we want to measure the carbon footprint of a medicine. And we can kind of do that. We could measure the carbon impact of that medicine. The problem is that's not the end of the story. We give somebody some medicine. What if the medicine doesn't work and they stay ill? They might go on to lots of other medicine and they have to start taking lots of other medicines. So does that mean we need to measure the carbon impact of all the future medicines that they might have because this one didn't work, or to treat the side effects of this first medicine, I guess? On the other hand, if the medicine was so bad that they died, then no carbon emissions. So it kind of makes our calculations easier. But we kind of need to factor it in because it's a real outcome of this medicine. It's a real outcome that some people will die and therefore will have no carbon emissions. If the medicine works really well, then the person goes out of hospital and has a nice active lifestyle, but they go on holiday and they drive and they have the heating on in the house. All these things have a carbon footprint. So do we need to measure all of that as well? You can see straight away that this is really, really hard to measure. It's not just looking at the footprint of the medicine, it's everything that happens afterwards. If this was a 21-year-old person, how do we measure the whole rest of their life and the impact that medicine might have had? It's going to be really hard to do that. And it's the survival thing. I mentioned that somebody who's dead has no impact, but that's kind of important for us to factor in here. Because I think best estimate I could find, this was from Mike Berners-Lee, Tim Berners-Lee's brother. I don't know if people have read his books. He does calculations on carbon footprints on almost anything. It's a good book because you kind of say, I want to buy a sandwich, a cheese and cucumber sandwich. What's the carbon footprint? And he'll have worked that out in this book, and it has pretty much anything you do. But overall, he estimates it's about 12.7 tonnes per year. Obviously, we're all different, but that's an average across the board. And that means when we're trying to evaluate a medicine or a device, in this case we've got just hypothetical device A against device B, I've factored in three different things. I've factored in the carbon footprint, the effectiveness of it and how long we live for, and the cost of it. In this case, device B wins on all three counts. It's got a better carbon footprint, it means you live longer, you get an extra month of survival, not huge but not bad, and it's cheaper, saves £20 for us. So we would pretty much always want to go for device B. It just wins on all counts. But when we start to measure that carbon impact, we're going to save 5 kilograms of CO2. That's lovely from using device B. But don't forget, because we're living an extra month, that's going to add 1,058 kilograms of CO2. Just one extra month of survival. So the net impact of device B in this case is actually 1,053 kilograms. That 5 kilogram saving was an absolute drop in the ocean, and that was only through one extra month of survival. And of course this is quite worrying to look at, because you start to think, we're doing all these nice things in the health system, switching to a slightly better intervention, and it looks like it's really good. But inadvertently, we're making everything worse. We think we're moving towards net zero, and we're not. We're moving even further away from net zero. So I genuinely don't know what the answer to that is. I don't think the answer is we just let everybody die, because that's not what the health system is there for. But I don't think net zero is just as easy as we're kind of making out, because little things like this could make a big difference. There's also a bit of a complicated thing to think about when we say we're not spending money on one thing, then we're spending money on another thing. So this is just a kind of picture of a health system as a whole. If we were going to spend more money on one area of the health system and invest a bit more into that particular area, then we could try to measure the impact on carbon or whatever else outcome we're looking at there. But of course, if we're spending more money on this, then we're going to be spending less money on something else in the health system. And we then also have to measure the carbon impact of spending less money on something else. I guess don't know this for sure, but I guess in the short term, if you don't spend money on something else, that probably reduces carbon emissions, I guess. But in the long term, I don't know, maybe that would increase the long-term carbon emissions, because if you're not doing things here, these might be preventative interventions here that stop things happening later, and actually by not spending the money on it now, we're just going to make it worse in the long run and have more carbon emissions. I don't know, nobody knows, and again, this is one of these really complicated things. You can't just say, we're going to spend a bit of money here and this is the impact it will have, because it has so many indirect knock-on effects everywhere else through the health system and makes things more complicated. So again, just to go back to our example here, device B, if you remember, was £20 cheaper, but we have to remember that that £20 will not just disappear, it will get spent on something else. Maybe it'll get spent on something that was worse than device A in the first place. At a very rough average, we can kind of work out that the NHS, for every pound it spends, we get 0.0014 tonnes of CO2 every time we spend £1. So therefore, for £20, if we spend that on something else, it will increase CO2 by a small amount in this particular case. But you can imagine if we scaled that up, if 500,000 people were going to switch from device A to device B, and that's 500,000 lots of £20 that we're going to reinvest somewhere else in the health system, that could increase the CO2 outputs by quite a lot as well. Not saying that's not a good thing, because it's good that we're spending money on other things, it's good that we're reinvesting it, and maybe it'd be lovely if we could ring fence any of the saved money from this to only be spent on environmentally friendly things. That would be a lovely way to do it, to say, because we've actually moved to device B for environmental reasons, we could have a legal obligation to say any savings from that have to be reinvested somewhere sustainable. We can't just reinvest it in something that's going to make things worse in the long run. But again, never seen discussions about that either. Ultimately, and this is what I really wanted to try and aim towards and finish on this point, that there will inevitably be trade-offs between health and the environment. So some treatments might improve our health but cause harm to the environment. Some other decisions might save harm to the environment but make our health worse overall. So there are some trade-offs. That worsening of our health might be directly or indirectly because of all the funding movements that I've been talking about. That's what I think we really need as a society to try to tackle this. So just to picture this, there will be this trade-off between health and the environment. Again, I like my graphs, so I'm going to show a scale here where we've got interventions that improve total population health and some interventions worsen population health. So it's a nice scale there. Some things do really lots of good, some things do lots of bad, some things don't really do much in the middle. And then on this scale, we've got things that improve the environment, things that make the environment worse, things that will harm the environment. So we might have an intervention, some new medicine, something, whatever it is, and it falls up here. That would be great, because this is something that actually does improve our health and improves the environment. We would always want to improve that kind of intervention. Anything down here, we would never want to do that, because it harms the environment, it makes population health worse. So those areas are nice and easy. We don't need to think about those too much. What's more complicated are the ones down here. So something that improves the environment but worsens our health, or something that improves our health but makes the environment worse. What's the trade-off? How do we make that trade-off? We're going to need some kind of decision rule, we would call it. So a nice diagonal line that says, for every amount of improvement to the environment, we're willing to lose so much health. Or, to put it the other way, for everything that improves our health, we're willing to harm the environment up to a certain level, but not beyond that. So we need to think about what kind of slope we're going to talk about here. Which kind of trade-offs are we willing to make? There will be lots and lots, I think, of interventions that fall into each of these two categories here. And the steepness of that slope is what it's all going to come down to. Are we willing to have the slope there, in which case we approve this, but not these, and we don't approve that, and we do approve these? Or will the slope be different? What kind of trade-off? How much are we, as a society, pretty much willing to give up our own health to improve the environment? What are we willing to do? So, I mentioned that there will be these trade-offs, but what does the public think about this? Why don't we ask them? They're the people that are going to be giving up their health. I wouldn't want to just leave it to a government to make these decisions for us. I'd want to ask people who are actually going to die earlier or live longer and suffer the consequences. So we tried to do this last summer. We asked 508 broadly representative members of the UK population about different hypothetical health systems. Have to emphasise it's hypothetical. It's obviously never going to be real, and that can bias the results clearly. But we said things like, imagine health system A and health system B. In health system A, the life expectancy is 82 years. In health system B, it's 84 years. In A, the CO2 emissions are high. In B, they're medium. In A, the impact on biodiversity is nothing. In B, the impact on biodiversity is moderate. And we gave them some descriptions to say what did we mean by moderate and mild or whatever. We tried to give them, they had a little crib sheet that meant this wasn't just completely hypothetical. And then they picked each one, and we asked them dozens and dozens of questions. They kept picking A, B, A, B. And what we gleaned from this in the end was that people were willing, or people said they were willing, to lose 0.75 years of life expectancy in order to achieve a 5% reduction in CO2 emissions. So what we'd say from that is whether or not that number is exactly right, whether that's an accurate number of people would be really willing to do it when it came down to it. We showed it was possible at least to ask people and get people to quantify this kind of thing. It wasn't just a case of saying, would you be willing to trade off some life expectancy? We could actually get them to pinpoint how much life expectancy they would be willing to give up. So 0.75 years, 9 months, is a reasonable amount. And I don't think there's a right answer to this, but I was pleasantly surprised that it wasn't just a fraction of a year. So that was quite reasonable. People were willing to kind of flip it round. People were willing to see a 5% increase in CO2 levels if they could get a 1.6 year increase to their life expectancy. So it's pretty much saying, if the NHS was to invest in loads of healthcare, and we knew it would be bad for the environment, how good would that healthcare need to be for you to be okay with it? And they needed to get, interestingly, more than double the increase in life expectancy to accept some harm to the environment. So again, that was interesting to see. There are similar results for biodiversity, and we quantified this by the number of species becoming extinct. People were willing to lose about a year and a half of their own life expectancy to save 100 species from becoming extinct, and then flipping it around, they were willing to accept 100 species going extinct to get nearly a 3-year increase in their own life expectancy. So really interesting to see what the public was making of this. Probably the most important thing that I found from the study was that the results, as you can imagine, substantially varied depending on the location of the environmental impact. We asked half the people, when we asked the questions, we described the impact as being in the UK. So when we talked about the CO2 being reduced or the species going extinct, we said that's in the UK. And then the other half of people, we asked exactly the same questions, but we said overseas. And the people that answered the questions for overseas gave about half. Their willingness to give up life expectancy was about 50% as much. I think that's intuitive. I think probably most of us tend to be bothered about things that are closer to home. Not saying we should do, but it's quite natural. When we're watching the local news, you get little stories that wouldn't make it onto the national news, but it's because it's local. We care more about it. So I think that's kind of understandable. But it does introduce quite a big problem for us when it comes to the NHS, because the NHS's job is to look after the health of the UK population. But suddenly we're asking the NHS to also think about the health of the planet, including 99% of the population being outside the UK. And I think probably legally that's an odd obligation for the NHS to suddenly think about. It's not really in their remit to do that at the moment. It probably should be if we're serious about all of this stuff. So my final slide here is the what do we do from here? 3 things, I think. So the first thing I would say is that we probably just need to accept that there's no magic answer to this. We can't just change the health system so that it's net zero and it carries on doing exactly what it's doing. I don't think we can do that. There will be some harm to our health if we do this. I'd like us to try to identify ways in which we can estimate the total impact on the environment, not just CO2, but all those different outcomes that we measured earlier on. And then most importantly, make some decisions about the trade-offs that we as a society are willing to make. And it's important to say, what does we mean? Do we mean the United Kingdom? Do we mean the world? Do we mean us right here now paying our taxes for the NHS? Or do we mean future generations as well? Because that trade-off is going to be quite different if we're talking about future generations and ourselves. But either way, whatever we're doing on any of these things, it is important to say these decisions have to be made soon. I said at the start of the lecture that we're not that far off that point of no return. I don't think we can just and ah about these things and talk academically about it. We need to actually make decisions about these trade-offs and then finally decide if we want to do something about it. We're willing to pay the price, which is absolutely fine, and then we can move on from there. So that's everything I wanted to cover. Thank you.